Good evening, everyone. Thank you for tuning in. For those of you who have been following this webinar series, welcome back. And anybody who's new, this is a webinar series. It's the penultimate session on an MRCS revision series. And the topic that we're going to be focusing on is essentially the abdomen. We've got GI and urology stuff, acute abdomen topics. Hugely common area that's obviously going to be tested a fair amount in the exam, but also probably a topic that most of you are pretty familiar with already. A lot of the topics are covered extensively during medical school as well. So the format of the session, again, like we've been doing throughout the series, is just to drill you guys on SBAs or MCQ questions. It's not really to teach you all the theory that you need to do, because it'd be impossible to do that in such a short amount of time. I'm sure you're all preparing quite hard for the exam, putting in the work. And so hopefully this is to test your knowledge, consolidate what you've been learning, pick up little tips here and there about possibly common questions or high yield topics that do come up. Okay, so we'll make a start. There'll be a poll. So for every question, there'll be a poll answer. Don't worry if you don't know, just give it a go and then we'll crack on. Okay, so we'll go on to the first question. So we have, again, it's quite this full stem isn't part of the poll because of the word count, but you can obviously refer to both. Okay, so a 44-year-old man who had undergone repair of his perforated duodenal ulcer 3 weeks ago presents to his GP with a 24-hour history of right upper quadrant abdominal pain, fever with chills and rigors, and shortness of breath. He says that the pain is radiating to the right shoulder tip. On examination, his temperature is 39.2, his heart rate's 110, blood pressure is 124/78. An abdo exam reveals tenderness over the right hypochondrium. Chest radiograph reveals right-sided basal atelectasis. What is the most likely diagnosis? I'll give it another 20 seconds or so, 30 seconds, just about half of you have voted. Okay, another 10 seconds or so. Okay, let's stop it there. All right, so we've got a range of answers from B across to E. B and E were the most popular answers there. E just about edged it with 38% of you who voted going for E. Now, this question, really we're focusing, as well as looking at the presenting complaint, we also need to put into context about what he's recently had done, which is essentially a pretty severe condition in regards to his perforated duodenal ulcer. All right, and that was only 3 weeks ago. So whenever a question comes up that shows and states that somebody has had recent surgery, whatever the subspecialty of surgery it involves, you will need to think about possible complications, especially if it's in a few weeks in which they represent. Of course, it's entirely possible that they come in with, again, another pathology, but think along the lines of, could there be a post-operative complication that's going on here? And with that in mind, the correct answer here is B, a subphrenic abscess. So well done, those of you who went for that. Okay. Now, looking at, and we can break down the stem in terms of what we're dealing with. And because it's quite a wordy stem, it's quite long. And that is something that occurs sometimes within the exam. You'll find questions, particularly clinical ones, that they'll be quite long-winded and a lot of text to read through for each for the question. Now, of course, in some of the physiology questions, pathology, anatomy, they might just be a simple, straightforward one-line question, but in some of the clinical ones, it can be quite long-winded. So you need to take care at least a little bit on what we're dealing with. So this patient, like we've mentioned, has recently, 3 weeks ago, had a perforated duodenal ulcer, and presumably, although it doesn't say here, that would have been repaired surgically, either laparoscopically or open. He would have had that repaired, and then probably a washout of his abdomen with antibiotics. But the key is the perforation, really, isn't it? Because then you'll have spillage into the abdomen, and that is clearly an increased risk factor for developing a collection within the abdomen itself. Now, in terms of subphrenic abscesses or other types of collections, the timeline can be variable, but typically it can usually be between, for subphrenic abscesses anyway, for it to turn into an abscess, it could be 3 to 6 weeks in which that may happen. So this fits the window. Obviously, it's never absolute, and there's going to be lots of variations clinically, but that is a typical time frame. In terms of the presenting complaints, he's coming in with right upper quadrant pain, fever, chills, rigors, and that all can fit with acute cholecystitis. They may be septic from biliary sepsis. Particularly on the examination, he's got tenderness over the right upper quadrant. That might be indicative of Murphy sign, but obviously that's not the only differential there. And I think the biggest thing in this stem that gives away essentially subphrenic abscess over acute cholecystitis is the fact that he's got more chest symptoms that you may expect from just acute cholecystitis. Okay. Now we know that pain can radiate from acute cholecystitis. So you may get shoulder tip pain. If it was really bad, you may affect a little bit of that shortness of breath, but it's probably unlikely to, on presentation, to have basal ectalectasis. Now, of course, you could go on and on about debating the different types of clinical things. The basal ectalectasis may be resolving from his previous admission. He may have sustained that after a duodenal perf, and he's recovered. But the strong emphasis on some of the respiratory symptoms, such as shortness of breath, the chest radiograph showing basal ectasis, and of course, he's got right shoulder tip pain. That all fits with a subphrenic abscess in the context of a recent intra-abdominal operation, which there was spillage because of the perforation. That fits more than an acute cholecystitis. Okay. Now, of course, this isn't, just looking at some of the options, it's not going to be pyelonephritis. He hasn't got any flank, loin to groin pain. He hasn't got any urinary symptoms. As well as you wouldn't really get any respiratory symptoms from that. Empyema of the right lung, again, you would probably see a lot more signs on the chest radiograph other than basal ectalectasis, as well as the fact that he, although you may get referred abdominal pain, it wouldn't present so much like this. Sclerosing cholangitis, again, potentially you've got right upper quadrant pain and things. It could be an acute flare of that, but generally sclerosing cholangitis, it develops a bit more insidiously, or you can get some obviously an acute flare-up, but again, I think in regards to the history of the first line where he's had that recent surgery, B is the most appropriate answer here. So we'll move on to the next question. All right, so a 50-year-old man is referred to the general surgical clinic with a 4-week history of epigastric discomfort and fullness. He reports occasional vomiting and early satiety. He has a previous history of alcohol abuse and was discharged from hospital 2 months previously, following treatment for acute pancreatitis. On examination, he appears clinically well, with a soft abdomen and mild epigastric tenderness and fullness. Preliminary investigations reveal a normal full blood count biochemistry with a serum amylase of 100 international units. What is the most likely diagnosis in this patient? Okay. Give you about a minute or so for this one, unless you all get your votes in. Okay, just over half of you have voted, so I'll give you another 20 seconds. All right, good. Let's stop it there. Thank you. Great. So let's have a look. So of those of you who voted, 44% of you went for B, pancreatic pseudocyst. And then there were a few spread out across C, D, and E. So we'll just have a look into this question. So again, for this question, the answer was B, pancreatic pseudocyst. Okay. Now, we've got a man who has had acute pancreatitis pretty recently. And that was 2 months ago. Okay. He's got a history of alcohol abuse, which clearly is a cause of his pancreatitis. All right. And now he's presenting with a few weeks of epigastric discomfort and fullness there. All right. Now, again, in this question, we're thinking about the possible complications or sequelae from an acute pancreatitis episode. And obviously, some of the things that you're going to think about is it chronic pancreatitis? Is it a pseudocyst? Is there pancreatic necrosis occurring? Is there an abscess that's formed? All of these things that should be going through your mind at this point. Now, in terms of his presentation, he's actually quite clinically well with a soft abdomen, but he does have mild tenderness in his epigastrium, and there's that fullness there. And that's the key clue in this question, that epigastric fullness. Another big clue in this question that would suggest that this is B, a pseudocyst, is a mild elevation of his serum amylase. So 100 is mildly elevated. And none of you went for acute pancreatitis because, of course, this type of presentation doesn't fit with that, and we would expect the amylase to be a lot higher. But a pseudocyst is essentially a fluid-filled collection, which is a cyst itself, around the pancreas because of that damage that the acute attack caused. You get auto-digestion. You get all of that amylase-rich secretions around the pancreas at the time of that episode. And then when that forms a wall-off cyst, it will have amylase within it. So the body still has a low level of amylase that will be detected if somebody has a pseudocyst generally. And so those few things within that stem will point you and should point you to being a pseudocyst. Now, a pseudocyst usually typically occurs, after maybe 4 to 6 weeks following the onset of acute pancreatitis. And so that is also one of the reasons why on an acute presentation, provided that there's nothing else, diagnostic doubt or any other severe presenting complaints that, cloud that judgment of this is a bond or acute pancreatitis with a high amylase, epigastric pain, etc., with an ultrasound scan that confirms it, you don't, unless there's doubt, you could actually, unless they're severely unwell as well, you could wait to do the CT abdomen pelvis a few weeks down the line. And the purpose of that mainly isn't to actually diagnose whether they've had pancreatitis or not, because that's quite clear. It's more whether they've developed some of these, complications. So you follow them up in a clinic a few weeks down the line with a CT scan. Have they developed anything? Okay. So B is the correct answer here. We've talked about why it's not A. In terms of pancreatic cancer, more in the stem of the question, you generally get kind of your typical painless jaundice type picture with somebody who has, symptoms indicative of malignancy, loss of appetite, all of these things. And I know he's getting early satiety, but the rest of the presenting complaint doesn't really fit with pancreatic cancer, nor does it with gastric cancer, really. And again, chronic pancreatitis, in that context, you would get a lot more. You wouldn't necessarily get so much fullness focally in the epigastrium area, although you generally get a lot more of bloatedness. You get, you may get malabsorption type picture. So things typically like a celiac disease, for example, where you get a bit of loose stool, you get flatulence, and this is all because the pancreas isn't secreting your normal digestive enzymes like it should, and so you get malabsorption problems. Okay, so we'll move on to the next question. So a 91-year-old man living in a residential care home is brought into A&E with a 24-hour history of sudden onset abdominal pain. On examination, he appears cold, pale, clammy. His blood pressure is 98/68, and his pulse is 94 and irregular. Examination reveals a soft abdomen with mild central tenderness and absent bowel sounds. A DRE reveals soft stool mixed with dark red blood. An ABG shows a pH of 7.22, bicarbonate of 18, and a base excess of -10. Which of the following options best reflects this clinical picture? Okay. All right. We'll give it another 20 seconds for this question. All right, well, let's stop it there, guys. Okay, great. So overwhelming majority of you went for A, mesenteric infarction. and that is the correct answer. So that's good. Okay, let's just talk about why. And hopefully most of you, I think the key trigger in this question to point you towards mesenteric infarction is kind of essentially the third line here. So you've got, after his blood pressure values and his pulse, it says they're irregular. Now, you know, a classic textbook question in which you would get a patient who's coming in with an acute abdomen, they're in a bit of shock, and they've got AF or an irregular pulse, you know, as well as some of the other symptoms, such as a PR bleed, that would all fit with a mesenteric infarction. So you get either, you know, an embolus or something thrown off by the AF, stuck into one of your blood supply tributaries to the bowel, either SMA, IMA, for example, and that cuts off the blood supply. Then you start getting ischemic bowel. You get blood from that, you get loose stool, you may get absent bowel sounds, and you'll generally have tenderness in the abdomen that will eventually go rigid, peritonitic, and you've essentially got yourselves a laparotomy on your hands. Obviously, following on from that, in terms of just the fact that he's got shock with a low blood pressure and mildly raised heart rate, of course, but you know, he's also got an ABG, which shows a metabolic acidosis. He's probably got quite a high lactate there, although it's not given it, but given the base excess is -10, it's likely he's going to have a lactic acidosis. And another thing, obviously, is the sudden onset of everything, especially if it's a mesenteric infarction from an embolus. Everything's quite sudden, okay? And they develop sickness quite early, all right? Now, some of the other options, of course, we've talked about why mesenteric infarction is the overwhelming answer here to explain that, but sigmoid volvulus, generally, you probably wouldn't get any dark red blood with that. And the caveat to kind of really the rest of these is that anyone, you know, you don't have to have AF for these surgical conditions to give you an irregular pulse, because, you know, we know that shock, infection, electrolyte abnormalities, they can all give you, you know, send you into an AF. And so irregularity alone isn't enough, but if you take in all the clinical symptoms along with that fact, obviously it's going to make that the most likely option here. Acute small bowel obstruction generally, again, doesn't present with with dark red PR blood. Toxic megacolon, you would probably generally get a little bit more of a history in the stem about the patient having kind of IBD type symptoms, or a background at least of IBD or symptoms matching up to that. All right. And again, a leaking AAA doesn't fit with all of the, although, you know, you have kind of a cardiovascular risk within the question, it wouldn't necessarily explain the rest of the clinical symptoms here. Okay. So we'll move on. And of course, as we're going, guys, any questions, put it in the Q&A and I'll try to tackle them where possible. All right. So a 29-year-old male presents to the surgical assessment unit with a 48-hour history of constant right iliac fossa pain. And this is associated with loose stools and vomiting. He has had similar episodes before, having been admitted twice recently, and on those occasions had conservative management. He also describes malaise and weight loss, which is attributed to his recent mouth ulcers. On examination, he has apyrexial, pulse of 90, blood pressure of 110/80. His abdomen is soft but tender over McBurney's point with no signs of peritonism. Blood tests reveal white cell of 13 and a CRP of 50. What is the most likely diagnosis here? Okay, I'll give it another 10 seconds or so. All right, let's stop it there. Great. So most of you went for D, Crohn's disease, and that's the correct answer. Great. So yeah, with this question, again, a lot of questions about, trying to get the diagnosis here, and you just need to fit the best as much as you can, the clinical picture with the signs and symptoms and any context in terms of their background. And the key, and I'm sure, well, most likely you would have been between D and E, perhaps because of that history of right iliac fossa pain, as well as obviously tenderness at the McBurney's point. So you've got Crohn's disease, which has a common presentation of having terminal ileal disease that would present with right iliac fossa pain. And then you've got appendicitis, which is kind of your classic one for RIF pain. The real key bits here is this middle of the stem where the patient who's 29, so it would fit kind of the age range, or the Crohn's or IBD has a bimodal distribution of incidence presentation, but with a 29-year-old it fits, and he's got weight loss and malaise, and as well as recent mouth ulcers. So they're probably aphthous ulcers, so it's features that fit with IBD. And so those key points should point you towards thinking about Crohn's disease more so than any of the other differentials. Somebody with, presenting with weight loss, loose stools, malaise, regardless of whether they got RIF pain or not, it's unlikely to be appendicitis. And so, yeah, and the majority of you got that question. So that's great, and we'll move on. So we have a 70-year-old man. He's referred on a 2-week wait to urology with painless hematuria. There are no other significant findings in his history and examination. He undergoes a cystoscopy, which reveals a transitional cell carcinoma. Which of the following is not a risk factor for bladder cancer? Okay, almost half, just over half of you have voted. So I'll give it another 15 seconds or so. All right, let's stop it there. Great. So we've got an overwhelming again. Most people went for D, renal stones, and that's the correct answer. All right, so risk factors for malignancies here, talking specifically about bladder cancer. All right. Now, smoking, obviously, is going to be a risk factor for pretty much all malignancies. So it's unlikely to be A. With B, schistosomiasis, obviously, less commonly happening here, but in, for example, West Africa or wherever, you can get schistosomiasis, where you've got indwelling water, like lakes, essentially, still water. that essentially can infect the bladder. So you get this the schistosomiasis affecting the bladder, and that leads to chronic irritation of the bladder, and that is one of the risk factors for causing squamous cell carcinomas rather than transitional cell carcinomas. But it is a risk factor for bladder cancer, okay? And in terms of C and E, both cyclophosphamide and aniline dyes, or other industrial type dyes that you get, they are also risk factors for bladder cancer. So any rubber industry chemicals, all of these things can also increase your risk of bladder cancer. And the one that isn't is renal stones. And if you think about renal stones, obviously, when they form, people will present with renal colic if it's large enough or irritating enough, but they will generally be treated, or they will pass on its own. And it's more of an acute event. And so it's unlikely to be a risk factor for bladder cancer, okay? Things within bladder cancer, for squamous cell carcinoma, which makes up maybe 10% of bladder cancers, they arise more from chronic irritation. So, as I mentioned, cystisomiasis, but otherwise kind of long-term catheterization is your other real classic cause for increasing the risk of squamous cell carcinoma. Otherwise, the rest, it's overwhelmingly increasing in terms of for the transitional cell carcinoma. Okay, so let's move on to the next question. A 56-year-old man presents with flank pain, radiates to his groin. He has low-grade fever. His abdomen is soft, but has severe pain on palpation to the left side of his abdomen. A CT-KUB shows a 9mm stone in his left ureter with associated hydroureteronephrosis. His urine culture has grown proteus. What is the likely stone composition of this man? Okay, I think pretty much we're all there, so we'll stop it there. Great. So, just over half of you went for E, struvite, and then maybe a quarter of you went for calcium oxalate. So the answer is E, it's struvite, all right. So the key really is you just need one key trigger word here, and you'll probably be have an association in your mind from kind of drilling past paper, question banks, that Proteus mirabilis gram-negative bacteria. If you've got that infection, it highly increases your risk of getting struvite. Okay, and struvite is renal stones, not very common, but when they do occur, it's from three minerals essentially, and it increases it. Proteus makes the urine more alkaline, so it increases your risk of struvite. And that's kind of a classic MCQ. You see a buzzword and the answer is most likely going to be E. Of course, still read the question carefully and consider all the options, but this one is going to be E, struvite. In terms of the other answers here, so calcium oxalate, if you've got a question in the exam about what type of stone or composition of stone is the most common, it's going to be calcium oxalate. Okay, that's the most common type of renal stone. Cystine is quite rare, and also a feature of cystine stones is that they're more likely to be radiodense. So you may see them on an X-ray as well. As obviously most patients go straight for a CT-KUB, but it's radiodense. Okay. Uric acid stones, obviously, they may give you a history of a patient who has, for example, features of gout. They may have malignancy or a hematological malignancy, for example, because you may get urase and building up, and you get crystallization to uric acid. Okay, and calcium phosphate is the most radio-opaque out of all of them. Okay, so I know cysteine can be radiodense, but calcium phosphate is the most radio-opaque. Okay, but calcium oxalate, the most common, struvite, proteus. Okay, so and we've got the same stem essentially at the beginning here. So it's the same man who has that flank pain. Okay, his abdomen soft, but has severe pain on palpation to the left side of his abdomen. The CT-KUB, like we said, showed a 9mm stone in the left ureter with associated hydroureteronephrosis. His blood pressure is 96/55, and his heart rate is 110. His renal function is a creatinine of 320 from a baseline of 110 and a eGFR of 10, baseline of 60. What is the most appropriate management of this patient? Give you about a minute for this one, unless you guys all answer. Okay, I'll give you another 10 seconds or so. All right, great. We'll end it there. Okay, so a mix of answers. Most people went for C, an urgent percutaneous nephrolithotomy, so PCNL. Some went for B, and others went, some went for D. The answer here is D. It's an urgent ureteric stent. Okay, it's a bit of a tricky question, this, and I do think this type of question is a little bit more on towards the tougher end of the scale. There are lots of nice guidelines on when to use kind of shockwave lithotripsy versus PCNL, etc. And it can depend on if it's a renal stone or a ureteric stone and their sizes. All right, but that's essentially irrelevant here for this question. Be familiar with that, because you know it might be a different context of the question, but I think the key point here from the stem is that the patient has a fever and they've got shock. All right, and it's low grade, but essentially, a low grade fever is still, you still need to be alarm bells ringing. His blood pressure is 96/55 and his heart rate is 110, and he's got a big AKI going on. All right, so this patient is clearly pretty sick. Now, when you've got an obstructing stone, which this man has, because he's got a hydroureteronephrosis, so he's got the ureter being dilated with fluid leaking out, as well as that kidney, and the pressure is building. Okay, so in a patient with a renal or ureteric stone that's causing an obstruction, there are a few occasions where you might want to stent the patient urgently. And one is sepsis. Okay, so evidence of sepsis, which this man clearly has, okay, is an indication to stent the patient. This is more to treat the sepsis because that's what's going to kill the patient first, than actually, trying to break down a stone and removing the stone, etc. Okay, this patient's going to be pretty sick. They're probably not potentially, they don't want to have a long GA or anesthetic, etc. You want to essentially ensure that his sepsis is treated. And the reason why you do a stent in an acute setting, by and large, is to ensure urine drains. Okay, it's not to allow the stone to pass, which probably won't if it's that large with just putting a stent in. It's to allow the flow of urine. All right, so that obstructive urine that's collected and probably leading to urosepsis, that can drain. You can give antibiotics, you can try to and then also obviously re-establish his renal function to closer to his baseline with resuscitation. Some other reasons obviously where you might want to stent in an acute setting for this sort of reason is if you have then a question which has complications of an AKI. So for example, resistant hyperkalemia, fluid overload, fluid edema, pulmonary edema, etc. So complications of AKI and sepsis are probably the two most commonly seen complications of an obstructing stone where you really need to do something about it, and putting a stent is one option. Another option I'm sure you are aware of is a nephrostomy as well. Okay, but I think in these type of MRCS questions, it'd be very, very, very harsh to add in an option for a ureteric stent as well as a nephrostomy, because both are legitimately good options potentially, but you would need a lot more information about the patient. So I don't think they would give you both, but one of, in an urgent setting where it's essentially a surgical and urological emergency, you would do that. Okay, so a stent or a nephrostomy to decompress them. And then you then think about, okay, let's treat the sepsis, let's get them a bit better, and then see what we do about the stone. Okay. So it's a bit of a tricky, tough question, that actually. All right, let's move on, guys. A 4-year-old boy is brought to the emergency department with vomiting and abdominal pain. His parents say that he's been unwell for the past 3 days with intermittent abdominal pain, vomiting, and diarrhea. He has not passed urine for more than 8 hours. He points to pain in the right iliac fossa. On examination, his abdomen is rigid and tender. His temperature is 38.3, a blood pressure of 80/60, and a pulse rate of 190. What is the most likely diagnosis? Okay, half of you have voted, so I'll give you guys another 15 seconds or so. Okay, let's stop it there then. Great, thank you. So, yeah, half of you who voted, which was the majority, went for D, it's bacterial peritonitis. Again, you can almost say it's a little bit of an ambiguous question, if you like, because bacterial peritonitis is quite a generic term, really, isn't it? It's not necessarily a diagnostic term. It doesn't say what the underlying cause of the bacterial peritonitis was, because, C could cause D, for example, A could cause D eventually, etc., etc. But for this patient, we want to be looking at, okay, his clinical signs, which is essentially a rigid and tender abdomen, that suggests he has peritonism. All right. He's also, you're thinking, could this be sepsis too? Because he's got a temperature of 38.3 and a low blood pressure and a sky-high heart rate. Now, of course, he's a 4-year-old boy, but even by pediatric ranges of your vital signs, that's pretty low and high in terms of a heart rate of 190. But put that in line with a fever, then you're on to thinking this patient may be pretty sick. And those put together would be in keeping with a bacterial peritonitis, or any form of peritonitis, but bacterial is the most common cause for peritonitis. Just looking elsewhere, he's had right iliac fossa pain, all right, and he's had intermittent abdominal pain for a few days, vomiting, and a bit of loose stool. And that could be in keeping with quite a few presenting complaints, like appendicitis, could be, even some of the options listed here, really. But it's unlikely to be intussusception purely, a pure intussusception, because it's unlikely they present so sick like this, okay? Now, of course, you can throw in the caveat that if it's left long enough, maybe they would, but generally with intussusception, they just get kind of this rumbling on of an abdominal pain that goes on and on, not sure why, and then either it causes a bowel obstruction or you identify it on obviously a scan of some form. Necrotizing enterocolitis tends to happen a little bit earlier. Now, it can happen in a 4-year-old as well, but generally it could happen earlier. And it generally doesn't last 3 days. If you get it, it's a very quick, sudden onset. Whereas 3 days for something like appendicitis, which is rumbling on, it's getting worse and worse and worse. It's kind of this crescendo over a couple of days or 3 days. And then it's what's happened here is a perforated appendix that's caused bacterial peritonitis. Okay. Again, a sequel volvulus, you're going to get a lot more of a bowel obstruction type picture. All right. And less so with the diarrhea. In E, a Meckel's diverticulum, it's just, the key is diverticulum. It's not diverticulitis, or obviously Meckel's is in the right iliac fossa pain, but they wouldn't present this sick, okay? So move on to the next question. We have a 68-year-old lady that presents to the emergency department with sudden onset epigastric pain. Her blood pressure is 100 over 80 and her pulse is 110, which is regular. She has a background of osteoarthritis and hypertension. Plain abdominal film is normal. An erect chest X-ray shows gas under the diaphragm. A rectal examination reveals melena. What is the most likely diagnosis? Okay, almost half of you have voted. We'll give you another 20 seconds or so. A little bit longer if needed. Okay, we're nearly there. A few more seconds. Most of you have voted now. Okay. All right, let's stop it there. Great. So most of you went for C, a perforated peptic ulcer, and that would be the right answer. So good job on that one. Obviously, for this patient who's coming in with sudden onset epigastric pain, wide range of differentials for that presenting complaint. They're a little bit unwell, going into shock. There's nothing specific on their background. Perhaps with the OA, there may be some history, you could think about, what if she's on any analgesia for that, particularly NSAIDs. Abdominal film is normal, okay? And with that film being normal, it's likely to then rule out B, because bowel obstruction, you're going to get dilated bowel loops on that abdominal film. There may also be features on a film of Crohn's disease, thumbprinting, for example. And again, doesn't suggest there was. And the rect chest X-ray shows gas under the diaphragm, and that's the key really, and it's the giveaway, which most of you probably would have gotten. You've got a pneumoperitoneum here. You've got a perforated viscous, which in here is the peptic ulcer that's causing it, which is likely in the duodenum. And so you've got essentially a perforated ulcer in the duodenum, which is causing gas under the diaphragm, giving the patient this sick presentation. So that's the answer. Okay. So next question. All right, a 42-year-old woman is admitted with right upper quadrant pain, nausea, and vomiting. She undergoes an ultrasound scan of her abdomen. This shows gallstones in the gallbladder, a thickened wall, and gas overlying the Hartmann's pouch and common bowel duct. What is the next appropriate step in her management? So we're thinking about the next appropriate step here. Okay, half of you have voted now. Okay, a few more seconds. Okay, let's stop it there. Great. So we're now talking about kind of what the next appropriate step is. All right. Not necessarily the next immediate thing, but you need, the next appropriate thing to do, essentially, to progress this patient's care. Now, looking at through the options, and there was a mixed spread of answers here. It was quite evenly spread, but the answer here is D. It's an MRCP for this lady. Okay. All right. So it was the majority of you who went for that, actually 38%, but there was still a bit of a spread across the other answers. Now, of course, it wouldn't be sensible to just get a repeat ultrasound because it's user dependent. It depends on patient factors too, depending on their habitus, body habitus, depending on, for example, this one has gas overlying structures that you might want to visualize. This patient, in terms of their presenting complaint, it's likely that your kind of differentials will include things that potentially could cause biliary sepsis. So you've got acute cholecystitis, for example. You may have cholangitis, even pancreatitis, for example, but lots and lots of differentials in acute abdomen stuff, of course. Now, although the ultrasound did show gallstones in the gallbladder, it hasn't visualized some of the other key structures that you do need to visualize in the management of this patient, okay? Because it affects what you then do in terms of an operative approach, okay? B is really appropriate thing to do in terms of if it was just giving antibiotics fluids, but you wouldn't just observe with that. You would want to do something else, either investigative or management wise. Okay, so A and B essentially we can rule out for now. Now C, a hot lap chole, which, you know, it is in the guidelines to do if it's early, if it's within a specific window for patient who's coming in with gallstones and acute flare-up, acute cholecystitis, for example. But what you want to do with, you know, when you want to plan for lap chole, you want to ensure that you visualize all key structures of the biliary tree, and that includes the common bile duct, because if you've got stones in the common bile duct, or you've got, you know, an obstructive stone there that's causing dilatation of the common bile duct, which is leading to, you know, bowel stasis and biliary sepsis, which is essentially going to give you that ascending cholangitis, you know, you then would not proceed with a laparoscopic cholecystectomy without resolving that obstructive stone within the common bile duct. All right, because even if you take off that gallbladder, you're still going to have that stone obstructing within the common bile duct. So you're not actually treating the core problem. All right, so C isn't appropriate. Then we're left with D and E, which is kind of a classic question that lots of people get asked about. When do you do an MRCP? When do you do an ERCP? And obviously the most important thing to recognize is that an MRCP is just imaging. It's an MRI. So it's purely diagnostic, whereas an ERCP is endoscopic. And so it is both diagnostic and therapeutic. Okay, now why would we do an MRCP for this lady and not an ERCP? Well, the main real thing to think about is the fact that an ERCP is really invasive, and it can have a lot of complications. It's quite a difficult procedure. So you wouldn't do it lightly, okay? And you do need real reason to do an ERCP. In this lady, we've got a good idea of what's going on, but because of the fact we couldn't visualize that common bile duct, we need further imaging to diagnose this patient. If that common bile duct was completely clear, it's a normal, you know, diameter in terms of for the patient's age, and she's just got gallstones with a thickened wall, so this is acute cholecystitis, then, you know, there's no need for an ERCP. So you would essentially subject this patient to an invasive procedure when they didn't need one. Now, of course, if the ultrasound did show kind of stones within the common bile duct, or an ERCP then subsequently also showed an obstructive stone, for example, then you would do an ERCP. Okay. So let's move on to the next question. A 10-year-old boy presents to A&E with a 24-hour history of right testicular pain. Examination reveals normal lying testes and some scrotal erythema, and swelling. The right testes, the epididymis and spermatic cord are tender, and Pren's maneuver leads to some relief of the pain. What is the most likely diagnosis in this patient? Okay, give you another 30 to 40 seconds. Half of you have voted now. All right, let's stop there. Okay, so the majority of you went for A, epididymitis, and that's the correct answer for this question. All right, so the key parts of this question to kind of, you know, whittle down your list of differentials and ruling out things is the fact that he has obviously tenderness, but also Pren's maneuver leads to some relief of the pain. Okay, as well as the fact that it's normal lying testes, okay, regardless of the erythema and swelling. Okay, so Pren's maneuver is just an eponymous name for a clinical sign that you can do in examination, which is purely by supporting the scrotum and lifting it up a little bit to see how that changes the pain. If the pain gets better with support and lifting up the scrotum, it's a classical sign of epididymitis, okay? And the opposite would be true if you've got a torsion, for example, it would exacerbate pain, okay? Obviously, the normal lying testes also point away from a testicular torsion, all right? In terms of scrotal erythema and swelling, that can happen across a variety of scrotal conditions. And so you can't, those aren't really distinguishing features for anything. All right. So in this question, epididymitis is the most overwhelming choice because of those things that I've just spoken about. Okay. In terms of the other ones, obviously, torsion, remember some of those things, acute onset, and you can have erythema, you can have swelling, but it's the pain that doesn't go away with either Pren's maneuver. You may have absence of cremasteric reflex, okay, and they'll be in loads of pain. Varicocele typically doesn't really cause obviously severe pain like this, and it's not really, doesn't fit any of these clinical signs. Again, same with idiopathic scrotal edema, it wouldn't really cause such tenderness in such an acute phase, and the same with an inguinal hernia. You wouldn't get some of these features, okay? So a few more questions for the evening. A 35-year-old male undergoes a terminal ileal resection for Crohn's fistulation. Which of the following conditions is least likely to occur as a result of his operation? Okay, we'll give up. Okay, half of you have answered, so I'll give you another up to 30 seconds or so. Okay, let's stop it there. Okay, so a little bit of an aspect of physiology, as well as obviously how Crohn's disease can affect patients. And this patient has had terminal ileal resection, so they've had a small bowel resection. And the key is obviously remembering some of the roles that the terminal ileum has in essentially absorption of nutrients. Okay, and the answer here was E, it's vitamin C. It's quite a tricky one, again, this one, because You could argue actually for anything in terms of malabsorption issues. You know, patients with Crohn's, if they've got loads of inflammation and has a flare up, you're not gonna absorb pretty much most things really. But actually, I think in the context of an exam and looking at the textbook consequences, specifically from the resection of the terminal ileum, that is what you need to focus on, okay? Now, just going through some of the options, obviously B and C are almost linked with each other, all right? So the key is obviously the lack of vitamin B12 that will be taken up, because obviously intrinsic factor that's important for vitamin B12, that's absorbed or reabsorbed in the terminal ileum. Okay, and so you get a vitamin B12 deficiency that will lead to a macrocytic anemia. And if left untreated long enough, you may get a rare complication of subacute degeneration of the spinal cord. Okay, so B and C, you know, they can be risk factors that can occur when you take out the terminal ileum, and that's why it's important to go on to supplementation. Okay. Then you've got kind of D, diarrhea, and obviously, you know, that's not, it's less really about kind of what a complication of not taking enough nutrients. It's more the fact that after that resection, you're going to, with Crohn's, obviously diarrhea is a very, very common presenting thing as it is anyway. So that is going to be pretty likely to occur in this patient, regardless of where the resection was, diarrhea would happen, okay? Now, in terms of A, and a few people went for gallstones, the reason why it isn't is, you know, there is a risk factor for increased risk of patients with Crohn's disease who had, especially if they've had terminal ileal disease or resection of the terminal ileum itself, to get increased incidence of gallstones. All right, so the terminal ileum obviously is a site for bile salt resorption from the gut. So you get bile salts released from the gallbladder, and then it enters the enterohepatic circulation to kind of recirculate that those bile salts. Okay. Now, when you have absence of reabsorption of the bile salts, it essentially stimulates an increase in the liver to try to make more of those bile salts. So you get increased bile salt synthesis. And when you do get that, you essentially, as a byproduct, can get more cholesterol buildup within the liver and gallbladder. And then obviously one of the most common type of gallstone makeup is cholesterol rich. And so that's, you do get an increased risk of gallstones. In terms of the other, in why E is the answer here, the terminal ileum is the main site for fat-soluble vitamins to be absorbed, and that includes A, D, E, and K, okay? And so with that, in terms of vitamin C, it's less so in the terminal ileum, but actually the jejunum that is responsible for the absorption of vitamin C, okay? And so because of that theoretical fact that vitamin C isn't absorbed in the terminal ileum, that's why that's the answer for this question. Okay, so a 71-year-old gentleman is referred by his GP to the urology outpatient clinic with a 3 to 4 month history of painless hematuria, increased frequency, difficulty in initiating micturition, and a loss of weight. He also complains of generalized tiredness, and occasional palpitations. He smokes 16 to 20 cigarettes a day. Prior to his retirement, he worked as a petrochemical industry. On examination, he appears pale, anemic. Abdo exam is unremarkable. The PR examination reveals normal prostate gland. What is the most likely diagnosis? I'll give you another 20 to 30 seconds. All right, let's end it there. Good. So yeah, most of you got this one, a bit more straightforward this time. It's E, transitional cell carcinoma of the bladder. You've got some pretty big risk factors in there, particularly the fact that he smokes a lot. He's worked at a petrochemical industry. Of course, obviously some of the symptoms that he presents with fits with a bladder cancer, painless hematuria particularly. And obviously the difficulty in initiating micturition points a little bit more towards a bladder cancer rather than a kidney cancer, which a renal cell carcinoma wouldn't be. It would fit less so with this, but this typically, it fits very nicely in terms of the risk factors. So as a presenting complaint with E, transitional cell carcinoma. Of course, we talked about the different risk factors between squamous cell carcinoma and transitional cell carcinoma. Typically, if they're getting at squamous cell, they will add in within the stem something about, something that will cause chronic irritation to the bladder, like a long-term catheter, like we talked about. All right. So the next question. So a 52-year-old female presents with a 48-hour history of abdominal pain, vomiting, and is feeling generally unwell. She says that she has also noticed her stools to become pale and her urine to darken in color. On examination, she's jaundiced and is tender over the right upper quadrant. An ultrasound examination reveals a dilated proximal common bile duct with intrahepatic duct dilatation. MRCP demonstrates a fistula between the gallbladder and common bile duct, and a large calculus is found in the common bile duct just distal to the fistula. What is the most likely diagnosis here? Okay, I'll give you another 20 to 30 seconds. Okay, let's finish there. All right, so for this question, we've got the majority of you who went for E, Miritzky syndrome, which is the correct answer. All right. Now, I had a few questions actually on gallstones, kind of biliary systems. I think I had about at least four maybe on gallstone, gallbladder things, either within this type of clinical question or anatomy wise, but it is a common theme that's tested. Now here, the key part of this answer, which would give it away, is essentially towards the end, it says there is a fistula between the gallbladder and the common bile duct. And that essentially, as soon as you hear maybe a fistula of some form, You're thinking Mirizi syndrome, okay. So what happens in Mirizi syndrome is essentially you get an impacted gallstone. It might be in the Hartmann's pouch just before the cystic duct of the gallbladder, which is large enough and impacted to then start compressing without passing on adjacent structures. Could be common hepatic duct or even down to the common bowel duct. And with that, you initially then get that obstructive picture, which this patient has, particularly with the pale stools and the dark urine, because that gallstone impacting is externally obstructing on the ducts of the biliary system. Now, if you have that long enough, you'll start to develop a fistula, all right? You get inflammation, you get scarring, and then that can eventually lead to an abnormal tract forming, which is essentially the fistula, all right, between the gallbladder and, for example, elsewhere, okay? So that is the reason why E is the answer here, okay? So, a couple more questions to go. So, we've got a 75-year-old lady from a residential home presents the clinic with jaundice and weight loss. She also complains of pale, buoyant stools and dark urine. She denies any pain or vomiting. Clinical exam reveals conjunctival pallor, yellow sclera, and a non-tender palpable mass in the right upper quadrant. Routine lab investigations reveal grossly elevated bilirubin and ALP and mildly elevated GGT. What's the diagnosis? All right, we'll give it another 15 to 20 seconds or so. Okay, let's stop it there. So most of you got the correct answer, which is C, carcinoma of the head of the pancreas. And the real giveaway again here is the key statement within the question, which you should try to obviously highlight when you're going through the stem, is the non-tender palpable mass in the right upper quadrant, okay, with the presence of jaundice. That should immediately think, all right, not painless jaundice is pancreatic cancer until proven otherwise, okay? So that, you know, this would be, again, a fairly straightforward question that will come up. You go through it, just be careful because of the stem. It's usually with these long stems, you know, they will try to trick you out with a statement here. But for this one, it's fairly straightforward. They've got, you know, obstructive symptoms in terms of the dark urine, the jaundice. They've got a history of weight loss as well. That points to a malignancy. And then again, that painless jaundice, it's got to be C, carcinoma of the head of the pancreas. All right. So moving on to the last question. We've got a 40-year-old man who presents with a 2-day history of constant worsening right upper quadrant pain, occasional rigors, and vomiting. She is a heavy smoker, consumes an average of 3 units of alcohol daily. On examination, she appears dehydrated and jaundiced with a temperature of 38 degrees. Her abdomen is soft but exquisitely tender in the right hypochondrium. Her blood tests reveal a bilirubin of 45, ALT 60, ALP 655, amylase of 250, white cell of 15, CRP of 35. What is the most likely diagnosis? Okay, nearly half of you have voted, so I'll give you guys another 20 seconds or so. All right, a few more seconds. Okay, let's stop it there. All right, so we've got a spread of answers, mainly between C to E, but mostly D. And D is the correct answer here, guys. It's cholangitis, okay? Now, a little bit, it can be a little bit tricky, this one. Now, we'll talk about why. Now, let me just start with why it's cholangitis, first of all. You've got essentially within this stem, you've got patient who's jaundiced. Yeah. You've got a patient who's got a temperature of 38 and rigors, okay, as well as right upper quadrant pain. That will give you the 3 signs for Charcot's triad, okay? And so with those things, you're already immediately thinking, okay, is this a type of cholangitis that's happening here? All right. And that's why this, again, looking at the blood test, bilirubin's up, you've got a greater rise in ALP compared to your transaminases. You've got a mild raise in amylase, and we'll come back to amylase because it is a bit raised, as well as slightly raised inflammatory markers. But the 3 clinical signs with rigors, jaundice, and right upper quadrant pain, you need to be thinking cholangitis off the bat, okay? Cholecystitis probably wouldn't give you all of those 3 symptoms in conjunction, and it would probably, you know, remember as well that, you know, with biliary conditions, a lot of the times they're just conditions within the same spectrum, and one is, you know, a lead on from the other. For example, cholecystitis, that starts off with gallstones impacting, you get inflammation of the gallbladder and an infection. But if those stones pass through and then gets jammed in the, you know, downstream bile duct, for example, you're going to get ascending cholangitis. All right. Cholelithiasis is just another term, obviously, for stones in the common bile duct. Okay, and this and that is tricky between B and D, because it is, yes, it's the presence of a stone in the common bile duct, but it doesn't necessarily mean, you know, they will have cholangitis. It's kind of like when you have a diverticulum or diverticulitis. Okay, so that's A and B, they're just terms for gallstones within the gallbladder or gallstones within the common bile duct, but it doesn't mean that they are causing a disease process. Okay. And then E, this patient, obviously with the amylase, it may throw some people off. But again, amylase, remember that it is a sensitive test, but it's not that specific. Okay, it is good, obviously, if you've got a raised, really high amylase with someone who's coming in with epigastric sudden onset pain, you're going, okay, pancreatitis. But when the levels aren't too high, you need to be thinking, okay, amylase isn't that specific. It is very sensitive, but that's because it can also be raised in a variety of other conditions. And the fact that obviously, rather than epigastric pain, this patient has right upper quadrant pain. Okay. So this question actually did come up, obviously not word for word, but pretty much this sort of question, it came up in my exam as well. All right. So that's the last question, guys. So, well done for going through those questions. Generally, really good poll answers, and a lot of you are getting the correct answer, which puts you in really good stead. I think acute abdomen stuff is quite, it's going to come up. It's bread and butter of surgery, isn't it? And it's going to come up a lot, but it's also, for me anyway, was quite a nice one in terms of, I felt like I already had a pretty good base of knowledge for it. And so you're just sharpening up when you study, and then obviously run through your question banks and looking for those key terms, distinguishing factors between conditions, for example. You really want to be going through those. And when you go through a STEM, systematically go through the different clinical signs. Can you fit them into the condition? And try to pick out those distinguishing things between them. Now, there aren't any questions in the Q&A at the moment. Obviously, if you are happy, I'm happy to answer any questions related to just the exam in general, the format, how it was on the day. Otherwise, the next session will be in a week's time. It will be next Thursday. Now, just keep an eye out for the Twitter feed, etc. Because the timing may be a little bit changed. So it could be, rather than 7 o'clock, it might be 7:30, but we'll confirm that for you guys, okay? But the next session, next Thursday, we'll focus on neurosurgery and ENT things, as well as, a few other little bits and bobs that we'll put in there. And again, as always, please, use this QR code, and there'll be a link in the chat as well if the QR code doesn't work, just for some really valuable feedback, please. Just spare a few minutes of your time. Would be really grateful if you could do that, please. And obviously, if there are no other questions, thank you again for attending. I hope it's been useful. Went through a lot, quite a few questions there. I know in this session, I didn't put down the kind of extra slides with kind of explanations on them. So I'm sorry about that, the lack of that in this session. But I wanted to try to get through a little bit more volume of questions for this one. Yeah. So again, in terms of preparing for the exam, obviously, lots of different resources out there. Question banks, I do think, are the most valuable in doing EMRCS and PASS test. Really, really good. I think EMRCS is a bit tougher and also maybe a little bit more reflective of the real exam, but PASS test is a brilliant resource, I found anyway, in terms of using it for recall. And, drilling anatomy, physiology, just going it over and over again, even doing the same sections, and really, really focus on, some of the real core topics. In my preparation, I know there are lots of other bits within the curriculum, such as your statistics, your microbiology, you've got kind of your other ethical questions. I really didn't spend a huge amount of time on a lot of those type of things. I went through the question banks on them and I tried to absorb what I could, but I didn't spend a huge amount on them. You know, within the exam, there'll be a few questions on them. And I did what I could for them. But I think for the MRCS, particularly Part A, you have to know such a breadth of knowledge across all the surgical specialties. It's a lot. And so, you know, don't stress yourselves too much or bog yourself down too much on learning, you know, loads of the different types of statistical analysis that you might do, for example. All right. But all right, so there aren't any questions. Once again, thank you for attending, guys. Please fill out the feedback. Otherwise, we'll hope to see most of you back next week, which will be our final session in this webinar series. And we'll wrap it up on that session.